I'm going to be discussing ketamine and its use for alcohol use disorder and relapse prevention. So to start off, I want to make it a little personal, and I want you guys to all think about somebody that you know struggles with alcohol use. So this could be someone who drinks too much and wants to stop but can't, or maybe they just kind of drink to the point of blacking out. Maybe they've developed really bad tolerance, or maybe you know those people who, before they have a drink, they start to shake. But this group of people that have a really hard time with alcohol and have a hard time controlling it. So first off, in terms of alcohol use. So in the UK, half the population drinks, and about 4 million people have an alcohol use disorder. And 20% of those people receive treatment. Now in the United States, about half the population drinks, but 15 million people have this disorder, and unfortunately only 7% of people receive treatment. So in terms of death, so we've seen the highest rate of death because of alcohol in the last 10 years. So in 2017, it reached its highest peak in over 10 years. And in the UK, Scotland has the highest rate of alcohol-related deaths than anywhere else in the UK, as you can see. But it has decreased by 21% over the past about 20 years. And you're more likely to die of an alcohol-related death if you are male, if you are between the ages of 55 and 64, if you come from a low socioeconomic group, and in the United States, it's the third leading cause of preventable death behind tobacco and obesity and activity. Now, one thing that I found really interesting is I'm going to talk about a study that we're working on in Exeter, but the participants that I spoke with and that I worked with, a lot of them were very health conscious. They watched what they ate, they exercised, they were very aware of their nutrition, which a lot of people, I think, are very health conscious in that matter. But the thing about alcohol is we ignore the health consequences that come with it. So anytime that a new stat comes out, don't eat eggs, that cause cholesterol. Everybody stops eating eggs. Do eat eggs. Eggs are great for cholesterol. Everybody starts eating eggs again. Or everybody jumps on a certain diet bandwagon. It might be, Atkins diet or the ketogenic diet or whatever it is. But alcohol is one of those things that we tend to ignore when it comes to our health. So we know that it can cause obesity. We know that it can lead to developing fat in our stomach, which can lead to diabetes. It can cause cirrhosis of the liver. It becomes addictive to some people, or it can cause accidents. Yet we tend to ignore this, I guess because it's fun and socially acceptable. So in terms of getting help, we have several options. They're not very effective. So first is self-help groups like Alcohol Anonymous. This requires you to, on your own free will, go a couple times a week or a couple times a day, call your sponsor. And then we have other things like medication. So there's relapse prevention medications and there's antidepressants. The things about this is, one, they're not super effective. In terms of relapse prevention medications, it's about a 10% difference in abstinence from drinking than placebo. It's not great odds. Plus, it's coupled with, one, it might take 1 to 6 months to actually take effect. Then you have to change the dosage sometimes to actually fit the person. And as well as they come with a slew of side effects. Now, I'm sure as a lot of you know, when someone comes in for treatment, they're not coming in for treatment because they're starting to feel bad. They're coming in for treatment because they've hit rock bottom. So if someone's hit rock bottom, they need a form of treatment, and then you hand them a pill and say, you might feel better in 1 to 6 months. You're probably going to have some side effects. By the way, don't drink on these. Okay, it's not going to be very effective. So then we have behavioral therapies, like cognitive behavioral therapy. Great way to help people, give them different skills to deal with coping and stress, dealing with high-risk situations. There's a couple problems with this. One, it's very time-consuming. Two, it can be really expensive, especially if insurance or whatever doesn't cover it. Also, when people tend to drink a lot, they have a decrease in what's called brain-derived neurotrophic factor, so BDNF. This is coupled with our long-term memory. So this is decreased. And so you're asking people who drink to learn new memories, learn new skills, and then practice them. Well, that's really difficult if this part of your brain is hindered. And drinking alcohol decreases neurons in your hippocampus, which is in terms of memory and learning as well. So think about trying to go to school or work after a hangover. It's really hard to retain information. And imagine this all the time and trying to learn these new skills to stop drinking. It's difficult. So, doing just therapy on its own is about 14% effective of keeping people abstinent. And then if you couple it with medication, that ups it to about 38%, which is pretty good odds, but again, you're talking a long wait period to feel better. And then detox programs, those are only 50% effective because about 40 to 70% of people who are actually in detox programs are spending their time craving and thinking about alcohol. And the amount of participants that I spoke to and doing pre-screens that told me how many times they went through detox programs, and then they're calling up a better study because they're still drinking. And the thing about clinical trials is only about 50% of people actually go through with the clinical trials. So they drop out about 50%. So in the typical population, 50% of people relapse at 3 months, 70% relapse at 1 year, and 90% relapse at 4 years. So it's not great odds. So why do we think that this population has such a high relapse rate? Well, it has to do with depression. There is a high comorbid depression in this population. So if we're talking about the typical people who are alcoholics, about a fourth of men, half of women have depression. But if you're looking at a clinical sample, that ups to 50 to 70%. So that's a large number of people who are drinking and also have depression. And we find that people in this group, that depression actually predicts relapse rates. So we know that people who have depression are more likely to relapse. So these people, at 3 months, 70% are likely to relapse. So again, population who doesn't have depression, 70% relapse in 1 year. But if you have depression, 70% relapse within 3 months, and 95% relapse within 1 year. Okay, so let's talk about why you guys are all here, which is ketamine. So, ketamine was discovered in 1962. It's a painkiller and an anesthetic, and it has a really good safety profile. And this means that it doesn't suppress respiratory function or heart rate or gag reflex. You also don't need patient monitoring equipment, so you don't need to be on a heart monitor or even have an IV hooked up. It's best if you do have these things, but you don't have to have them, which makes them great in second and third world countries and war zones. For this reason, it was put on the World Health Organization list of essential medicines, and it's used widely throughout the world. It got the nickname the buddy drug during the Vietnam War because soldiers could carry it with them and administer it to a fallen comrade without having to be a doctor. And this actually decreased mortality rate from the Korean War to the Vietnam War cut in half because of this one medication. So because it's so safe and effective, it's used with children and when they need anesthetic, as well as animals. So if you go to your veterinary clinic and your dog or cat needs surgery, they're likely to be given ketamine. It has a really short acting half-life of just 2.5 hours, and you start to feel the effects within 20 minutes, and they're gone within 40 to 50. Okay. So, for everything that is out there, there is someone who is going to use it recreationally and those people who are going to abuse it. When used clinically, trials have shown that there is little to no risk of abuse, dependency, addiction. Now, when used recreationally, that's different. So, this gained popularity in about the 70s when they were discovering mixing it with LSD, and this created a near-death experience, and people were really interested in this. Then it gained another popularity in the 90s when the rave culture was happening because it was cheaper than cheaper than cocaine and MDMA. And recently we've seen another boom in it with the club drug called Calvin Klein. I'm sure some of you have seen it in the news. It has killed a couple of people recently. It's a mix of cocaine and ketamine, which is extremely deadly, especially when used in this club scene. Because you're not drinking water, you're drinking alcohol, your heart rate's up, you're hot. This can really be a deadly combination. And we've actually seen a doubling of adults over the age of 16 use ketamine in the last year. There are a slew of side effects if you use it recreationally and habitually. We get a lot of this information from Southeast Asia, where it is the second most recreational abused drug, second to heroin. So as you can see, there is a load of things that comes from this. One big thing is called the K bladder. So this is what happens when the bladder, the inside becomes corroded and the bladder actually shrinks. So people who have K bladder have to go to the bathroom more often. They have more infections because of it. And we actually see K-bladder highest in the UK than anywhere else in Europe. As well as about 32% of people who use this quite often, they develop psychotic episodes, psychosis, and schizophrenia-like episodes. And about 6 to 12% of people develop seizures. Okay, so for everything, there's always a light side and a dark side. And actually, with ketamine, the dark side has some positives as well. So the light side of ketamine is it is a psychedelic when used at low sub-anesthetic doses. So when you give it to someone as an anesthetic, they go to sleep. And then if you do it at a very low dose, they have a really profound psychedelic experience. It can change their mind, alter their perception, give them a new look on life. You guys all know the psychedelic experience stuff. But the dark side is called the K-hole, which I honestly think is the worst name in the world because it's really hard to take it seriously when it's called a K-hole. So this is when someone has a K-hole experience, they become paralyzed. It's hard for them to breathe. They might not be able to even blink or talk. A lot of people feel like they're dying. This can be extremely dangerous when used in a club environment because if you have K-hold on a bathroom floor, guess what? You are open to someone attacking you. Now, this isn't just that someone's done too much. This can actually just happen to someone who's had a dose that's specific for their height or weight. But the thing about that is what positives come out of it is they've actually seen that people who have a negative experience on ketamine like this actually have a longer remission rate if they have a dependency. So for example, if you are alcohol or heroin or cocaine dependent and you K-hole, you have more remission than someone who doesn't. And that might be that it's close to a near-death experience, and when someone has a near-death experience, it really changes their outlook on life. We've also found that people who have a really long history of psychedelic use actually have a diminished return from ketamine. So if you're used to taking psychedelics and you take ketamine, you don't really get that profound experience that someone would who is brand new or novel to this world. Okay, so psychology and ketamine. So I find these really interesting. So we know that ketamine is really, really effective with people with depression, especially major depressive disorder and treatment-resistant depression. There's been over 2,000 studies in it. It's pretty safe, pretty effective. So what's going on? Well, we don't really 100% understand how ketamine works. We're still trying to figure that out. We've just kind of hit the tip of the iceberg. But this is the part that I get really excited about, is how ketamine affects sleep in this population. So what ketamine does is it decreases night wakenings. It increases slow wave sleep amplitude, REM sleep, and total sleep time. And that is really interesting because in this population, it does that. In a non-depressed population, it actually decreases REM. So what do we think is going on? So the thing is, with the BDNF, which is your long-term memory, that's decreased, but then ketamine increases BDNF, and that helps increase your memory. But then when you increase during slow wave sleep, you incorporate short-term memory into your brain, you incorporate your memory, it's short-term memory is being consolidated during slow wave sleep, and your long-term memory is being consolidated during REM. So if you're having this very profound experience that's like life-altering and life-changing, then in your brain, you're increasing this factor that helps with long-term memory. Then you're increasing your slow wave sleep and your REM sleep, which is helping you consolidate memories even more. That this might be why it's helping people either get over depression or it's having a long-lasting effect of it. So I think we need to understand this a little bit further in terms of sleep and how it's helping specific populations. So other populations that it helps with are populations that have high risk of depression as well, so suicidal ideations, bipolar disorder. They've actually seen a decrease that if they give it to people with PTSD, they've actually seen about a 65 to 70% decrease in hospital admissions and hospital stays. And other dependencies like cocaine and heroin, when giving them ketamine coupled with psychotherapy, there's about a 50% chance of remaining abstinent over a couple of years. And eating disorders, one that I'm really interested in, they actually saw an 80% remission in people who were treatment resistant with eating disorders and given ketamine. But this was a while ago, so I think that we need to have a lot more research in this area as well. Okay, so with ketamine and alcohol use. Why do we think that ketamine will help with alcohol use? Well, first, there was some pilot work that was done in Russia in 1997. And they gave people 3 doses of ketamine coupled with So they gave people 3 doses of ketamine coupled with psychotherapy, and they found that 65.8% of these people remained abstinent from drinking over a year. And then in 2007, they did the study again and found a 70% remission rate. So 70% is kind of like this magic number with this group. It seems everything kind of happens with 70%. But the problems with these studies is they did not live up to the gold standard we have today for research, so they weren't random. Okay, so where was I? Oh yeah, so it doesn't live up to the gold standards that we have today in terms of research. So that it wasn't randomized. Participants could choose whether they received ketamine or not. The researchers and the participants weren't blinded. So there's all of this bias that came into it. But doesn't mean that we need to throw it away. It is really good pilot work. We also know that with rat studies, that rats that are alcohol dependent given ketamine, they no longer seek alcohol and choose to drink it. We also think that there's a potential biomarker in people as well. So there was a group of people with major depressive disorder who were given ketamine. Those who had a family history, not an alcohol use disorder themselves, but a family history of alcohol use, they actually responded more positively and longer to ketamine than those without a family history of alcohol use. Okay, so some possible avenues of why we think ketamine can help with this group. So I've talked about the depressive symptoms a lot. The thing is, when people stop drinking, there's always a chance of relapse. But that chance is significantly higher during the first few days of not drinking. And the thing is that ketamine has such a fast-acting, rapid antidepressant profile that works so quickly that we think that it happens during that really vulnerable period, and that helps keep people from drinking for a while. Also, neurogenesis. So like I talked about with BDNF being decreased, as well as there's neuronal death in the hippocampus. And with neurogenesis, ketamine creates these new neurons kind of fire in the hippocampus, which means that they're more open to learning and retaining information, especially if you couple that with cognitive behavioral therapy where you're teaching them new skills. We also think that this helps with enhanced learning, retaining the information, as well as a profound change in experience in their life. Okay, so the study that I'm working on right now is called KARE. This has been going on since 2015. We started recruitment in 2016. And we wanted to recruit 96 participants between London and Exeter. And I'm happy to report we are randomizing number 96 in 2 weeks. So, yay! We are all extremely happy about that. Thank you. I can't take really any of the credit for this. It's everybody else who did this. But we're really thrilled that we've hit our number by our deadline. So with this group of people, we wanted to do randomized, placebo-controlled, and it's blinded. So people are in one of 4 groups. They are either in ketamine plus CBT, ketamine plus alcohol education, placebo, which is just a saline drip with CBT, or placebo with alcohol education. So people are in this for 6 months. They only come in for 10 visits, though. So they'll come in. We do a pre-screen on the phone. If they're eligible, we bring them in for screening. And we give them a whole bunch of psychological, cognitive, and medical tests. If they pass with flying colors, they're in the trial. And then they'll have 3 infusions of either ketamine or placebo. And they have 7 sessions of cognitive behavioral or psychoeducation. During this time that they're receiving the infusions, and the psychoeducation is roughly a month, they wear these lovely scram bracelets around their ankle. It looks like a prison tag. But this keeps people honest because it takes a little bit of sweat every 30 minutes to see if they're drinking. And then they go away, and then they come back at 3 and 6 months, and during that time they keep drink diaries. And this is every time they drink, they just write down the date and the amount, because we're curious to see if ketamine, or ketamine plus CBT, helps people remain abstinent over 6 months and the rate of relapse. And when we do CBT, it's a very formulated sort of like everything is kind of spelt out for us. But the thing is, it's specialized for each individual person. So even though we're focusing on high-risk situations, coping skills, trying to help them do relapse prevention, and then doing mindfulness, each thing that we're doing is specific for that person. So maybe a high-risk situation is the pub that's down the street for this one person, but for another person it might be their kitchen, and another person might be a friend's house. So we cater it for each person, yet we keep the curricula pretty standard across the board. And if they get alcohol education, they learn what's addiction, how does alcohol affect your brain, your body, your sleep, your reproductive system, as well as how does it impact growing adolescents. So some lessons that we've learned from this, and I'm sure next year when we have data to actually report on, which I'm excited to see, we'll have a lot more lessons we've learned. But on the surface, there's a few of them. So one, when the study first started, we had inclusion where you had to have alcohol abuse and you had to have depression, but you couldn't be on an antidepressant. You guys can imagine how hard it is to try to get 96 people who fit that tiny little category. So we removed the depression point. We said you had to have an alcohol abuse, but you couldn't be on an antidepressant. That still really narrows down the amount of people you can get. We got them, obviously, but maybe if we make this a larger trial, then maybe we can include people who've been on an antidepressant for over a year, because then we know how it affects their brain and their mood, and then we can compare them to people who aren't on it. Also, when it first started, people were required to wear that ugly scram bracelet for 6 months. You can imagine not many people want to walk around for 6 months, not only with a prison tag on their ankle, but getting looks from people. So we decreased that to 1 month, and people were well more open to it. Another thing is the environment. So at the top here is the RILD where we do our ketamine drips or placebo drips, and it's very clinical. So it has to be clinical because we have a whole bunch of, we have an anesthetist, we have nurses, we have clinicians, everybody's working, and you have to be able to get a crash cart in. But it's not very conducive to a very therapeutic, environment where you want to be processing maybe your childhood and your emotions, like the bottom here where you have an eye mask and someone's holding your hand. So maybe next time we keep the environment the same, but we offer people an eye mask to wear, because especially people who are K-holing, looking at those really ugly curtains is quite distressing. And one other thing that wasn't really a lesson learned, it was just more really interesting when we kind of looked at recruitment, is the amount of people who contacted us and said, I want to be in this study. They would contact us and we would say, great, here's some information, please give me your phone number, time to call you, we'll do a pre-screen. The amount of people who contacted us, only half got back to us with their phone number and a time that they wanted to be contacted us. And then of those that we pre-screened, only a fourth were actually eligible to come in for a screening visit. And of the people who actually came in for a screening visit, only half were randomized. So you can see how little it dwindles down that we get people. So that is it. This is a huge acknowledgement. These are all the people who are responsible for all 96 participants. And a huge shout out to Celia Morgan, Lorna Hardy, and Sarah Staton, and Beth Marsh, who have just been fantastic as I got acquainted with this position and this trial. Thank you so much for your time.